Everybody, and welcome to the Queen Village Neighbors Association monthly community meeting. My name is Eleanor Ingersoll, and I lead the Queen Village Neighbors Association. The purpose of this meeting each and every month, except in the summer, is to bring to you timely topics for review and conversation. Tonight, I am very happy to welcome back Dr. Kathleen Sullivan, Professor of Pediatrics and Chief of Allergy and Immunology at the Children's Hospital of Philadelphia. If you were with us in November, Dr. Sullivan joined us to discuss news as it was just breaking of the vaccines, and she did a fantastic job of walking us through how the virus operates, as well as how to avoid transmission and how that transmission can happen. So since that time in November, many developments have taken place. There have been multiple vaccines approved and released. There has also been a scare of strains that are more communicable, as well as projections for herd immunity. It's a lot of information for any of us to take, and that's why we're so happy to welcome Dr. Sullivan in to make a presentation that you can hear, listen to, absorb, and then we welcome questions and comments, which you can send to us via the chat option. And I'll be very happy to relay your questions, concerns, or conundrums to Dr. Sullivan. So without further ado, I pass the Zoom floor over to you, Dr. Sullivan. Thank you.
Thank you, Eleanor, and thank you, Lucy, for help getting me organized. So I have a fairly ambitious agenda for tonight. I know there are a lot of questions, and I want to try and give you the most up-to-date information possible. I sort of subtitled this, "Where are we now and where are we going?" But I will be talking primarily about the vaccines and the variants that have emerged recently. Those are enormous public health problems for us, and particularly in large cities like Philadelphia. You will notice that I use this mural arts poster on my title page. I'm a big fan of their work, and I love the sentiment that we can beat it. We can, but it's a road ahead of us for sure. So this is what I'm going to cover. It will take about 30 minutes. I wanted to leave a lot of time for questions. Last time people asked really insightful questions, and I know you probably have pressing concerns. So I'm going to just briefly talk about where we are in the world today. The variants definitely deserve attention tonight. And then I'll talk about the vaccines, a little bit about what Philadelphia's status is. And you will notice in very tiny font, I wrote about vaccine access. I'm not an expert on the distribution side of things. As everyone on this webinar knows, it's been a bit of a mess in Philadelphia. I don't have a lot of answers, but I will try to at least give some insights. So with that overview, let's go ahead and get started. Where are we now? So someone reminded me today that we are just about a year from the time that Philadelphia started seeing infections. It's 100 million cases worldwide. It's really hard to imagine another force of that magnitude. 2 million deaths worldwide. And here in the US, it's 25 million cases and 400,000 deaths. We estimate that we'll be at about 500,000 deaths by the end of March or the beginning of April. So this is a tragedy of major proportions. And I think sometimes it's hard to really wrap our minds around the magnitude of this. I sometimes talk to colleagues that are in smaller cities, and to them, it still feels a little abstract. We can say the numbers, but I think in a big city like Philadelphia, most of us know someone who's been directly impacted by COVID-19. So I think it's a little more in our minds. This is a map of the cases. You can look for this yourself. It's put out by Johns Hopkins every day. You just Google Johns Hopkins COVID map and this pops up. I'm showing it this is not going to be a political talk at all, but I do want to say that the US has handled the pandemic worse than most other countries. If you look at our cases per capita, we're like number 10. So there's no reason for a country that has as many resources as we do to be having that much trouble with the pandemic. But we can't we can't undo how we got here. We can only move forward. So let's talk about the variants, which also requires a bit of a look to the past. But I am going to end by saying what I think they mean for us, excuse me, here in Philadelphia. So first of all, what is a variant? So many of you, I suspect, have done 23andMe, right? You spit in a little cup, you mail it in, and it looks at your DNA. And so what is it doing? It's actually sequencing your DNA. And if you've done this, you know that you can tell it when you send in your sample that you're related to this other person, that so-and-so's your mother and father. But 23andMe will also find people that are related that you maybe didn't even know about. And the way it's doing that is it's looking at the relatedness of the DNA. So the more the DNA is shared, the more related you are. The less sharing there is between two people, the more distant you are. It's the same thing when they're saying, oh, you're 1/4 Estonian and you're 1/16 Maori. It's the same thing. They're looking at the sequence of the DNA and saying, oh, look, there's a lot of matches to Estonia, not so many matches to Maori. And so they're making an ancestry assessment based on the sharedness of DNA with those ethnic groups. So that's not what we're here to talk about, but it's exactly the same concept for viruses. Oh, sorry, I forgot I put this in. So if you watch the Henry Louis Gates show on TV, you will know that Cory Booker Jr. and RuPaul were discovered to be cousins on the show through DNA analysis. Sorry, I forgot I put that in. So this idea of relatedness and shared DNA sequence is at the essence of our discussion about the variants, which is why I bring this up. So we have chromosomes, 23andMe, in fact. Viruses have a heritability as well. And if you look at this picture of the SARS-CoV-2 virus, the virus that causes COVID-19, you'll see this thing that looks like a slinky in the middle. That's the virus version of a chromosome. And so you can look at the relatedness of different viral isolates to find out how close they are in terms of their relationships. Why am I mentioning this? Well, I'm just going to take you through 3 snapshots in time. I think people think, oh, the variants, they're this new thing. That's actually not true. This is a snapshot I took off of a COVID-19 website that tracks the variants. You will see if you look carefully that there are 2 colors on this map. There's the dark purple virus, which is one family of viruses that originated in Wuhan, China. If you look in the United Kingdom and Mexico, you will see that there's a lighter blue, a teal. That's a second family. So even by the end of 2019, when we weren't really paying attention to COVID-19, there were already 2 strains, 2 families of viruses as denoted by these colors. If you fast forward to the summer of 2020, you will notice that there are about 4 main family members circulating. So there were already mutations even by the end of 2019. Now in the summer, there are more mutations. Each color here is a variant. And you're probably thinking, but I didn't hear about variants back in the summer. That's right. These were being tracked as part of surveillance, but they weren't medically meaningful. If we look at one more map, these are now the viral strains that are circulating just in this calendar year. So from January until now. And you'll see it's completely different colors, right? So this virus evolves over a very rapid time frame. That's true for almost all viruses. So why are we talking about variants now? Why is it a big deal if these mutations and variations in the sequence have been accruing this whole time? It's because the ones now are medically meaningful. And I have one punchline that I hope you take home because this is really critical. The more the virus reproduces, so think about those 3 maps and how there were more and more and more variants. The more the virus reproduces, the more variants will show up. It's just a law of virology. that as these viruses reproduce themselves, they will acquire more and more mutations. Those mutations are what dictates that one is a variant from another. But as I said, not all variants matter. So why are we talking about variants now? So this is the SARS-CoV-2 virus. You have seen pictures that's on the news almost every night. And what I'd like you to pay attention to is this spike protein, the thing that looks like a pink palm tree. So this is on the surface of the virus, and this is the protein that latches onto our cells that allows it to actively infect us. So without that spike protein, this virus would not be able to infect us very easily at all. So the spike protein is sort of the thing that reaches out, grabs onto our cells, and leads to active infection. So the variants that we care about right now today, that doesn't mean there couldn't be variants down the road that affect another part of the virus, but all of the variants that I'm going to talk about today affect that spike protein. So what are the ones that you're hearing about in the news? So I'm going to start with the B117 variant. I'm not going to use that nomenclature because I know it's hard. I'm going to call it the UK variant, which I think is how most people know it. So that's been in the news a lot. I'm actually going to show you a graph of its emergence in a minute. People are talking about it because it spreads faster. It spreads more easily from person to person. There's a question about whether it causes more deaths or not. So there have been a couple of studies, and if it does impact the mortality rate, it's just a little bit, not a lot. So the UK variant you have probably heard about. Another variant in the news is the South African variant, also known as B1351. I know they don't get very sexy names, but that's just the tradition in virology. This one is a concern because it also is transmitted more easily and the vaccines don't work as well. So this one has some real potential for harm. And then there's the P1 variant, or the Brazilian variant. We don't know a great deal about it, but it has the mutation of the UK variant, the mutation of the South African variant, and another mutation that seems to allow it to evade vaccine protection as well. I'm not going to talk about the Los Angeles variants because they have not been characterized very well, but there's active surveillance for their behavior and also what changes in behavior those mutations cause in the virus. So a little bit more detail about this UK variant. So the graph that you see in front of you is the cases in England. And you will see that they had a fall surge, just like we did. Many countries did. There was the spring surge, a little bit of a lull in the summer, and then cases of COVID-19 re-emerged in the fall. You can see the fall surge is mostly the light purple strain. That's the original European strain. But starting in December, you start to see that dark purple strain, and you see a big peak that is even larger than the fall surge. So that dark purple is the UK variant. Now, if you look carefully, way over on the left of the graph, you can see that there were a little bit of it way back in September, but it really took hold, and then it quickly became the dominant strain in England. So if you were going to sequence 100 COVID-19 isolates in London, the likelihood is that they would all be this UK variant right now. You can see it has completely outcompeted the original European strain. That speaks to how rapidly this virus, once it gets a toehold in the community, can spread. Remember, the mutations allow it to infect more people and to spread more easily. Is the UK variant here? It is. These are graphs taken as of February 1st. It's probably even more. If you look back at the data from England, you can see it sort of perked along at about 1% for a while, and then it just exploded. And that's typical for these strains that have increased fitness, which just means they spread more easily. So where are we at in the US? There have been multiple isolates in the US. I'm pointing to Florida in this slide. Florida, I hope no one on the webinar is from Florida. So Florida has some of the laxest public health measures in the country, and also high density populations in their cities. So Florida has always had rather rapid spread. And so the UK variant is in Florida. The highest rates in the country are in Florida, but it's still less than 1%. So it's still not the dominant strain. But some epidemiologists are predicting that it will, just like it did in England, it will outcompete the other strains in the US and be the dominant strain by springtime. I will get to how likely that is in a minute, but there are definitely epidemiologists who are projecting that. So just to sum up the UK variant, it's mostly a public health issue. We need to really get to work on restraining it because it does spread so much more easily. But all of our usual maneuvers work. So washing your hands, wearing a mask, the vaccines work, which is really important. And I'm not going to talk much about these antibody cocktails, but this is what is given to people early in disease to try and prevent it from becoming a more serious infection in that one person. And those antibody cocktails work as well. So one of the things we've learned about how easily this particular variant spreads is all of the countries that reported the virus, the UK variant, after it was originally detected, all had multiple flights from London. So it just takes one asymptomatic person on a plane and you can really drive the emergence of this variant in that country. I'm going to turn my attention now to the South African variant and the Brazilian variant. These are actually a bit more worrisome, and you'll see why in a minute. So I'm not going to use the mutation nomenclature. I just put it to keep myself straight. So the mutation that causes easier transmission is the same as is seen in the UK variant. But the South African variant has, in addition, it has a mutation that allows it partial escape from antibodies. What do I mean by that? Imagine the spike protein on the surface of the virus. If antibodies bind here, but this is now mutated, the antibodies won't bind as well. It is by far the most dominant version in South Africa. And so it's got the same variant as in the UK strain that allows easier transmission. And now it's got this variant that allows it to have partial escape from the vaccine. So it has spread, it has spread quite widely in Southern Africa. There are cases that have been identified in the United States. But they are not related to each other. And so while it is a handful of cases at the moment, we presume that there is community spread of this variant. So not to the same extent as the UK variant, but we presume it is entrenched in many communities. It's, I believe there was a case identified in Philadelphia recently. So the last variant I'm gonna talk about is the Brazilian variant. So these first two mutations are the same as in the South African variant, but now the Brazilian variant has a third mutation, and this also allows it escape from antibodies. And when I say escape from antibodies, that means the vaccines won't work as well. So for the South African variant, the vaccines were about half as effective as they were for the original European strain. For the Brazilian variant, we don't have the same data, but we presume it would be even less than 50% because there's this additional mutation. So let me just illustrate why this is a problem. So Manaus, Brazil. Manaus is a city in the middle of the Amazon. Brazil does not believe in public health measures as a country. Their president has had a great deal of denial. They don't have many resources for masking, glove wearing, anything like that. So in Manaus, in the summertime, they had a major outbreak. That's the first peak that you see. It's hospitalizations and deaths. So that first peak that you see on the left was what happened in the spring and summer in Manaus. As a result of that, and because they really didn't have many resources or public health strategies, over half of the population of Manaus was infected. Over half of the population of Manaus had antibodies to SARS-CoV-2. And so they perked along through the summer and they, removed some of their public health strategies. They let people go back to the movies. And then the new variant was detected right where I have my red arrow. That's the first time they found the variant. And after they found the variant, there was this explosion of cases in Manaus. So imagine, they thought, we've got herd immunity. We've got 50% of our population has antibodies. How can we have another peak as high as the previous one? We've already got immunity. And that didn't happen. And it didn't happen because this variant is not protected by the antibodies that were made to the original European strain. This is the importance of the variants. And this is why people are tracking them so carefully and why you're hearing about them now. So that brings up the issue of herd immunity. So we've been hearing about this since way back in February a year ago, right? Oh, we just need to get herd immunity and then we can go back to doing everything we want. We can take our masks off. So at the time, I remember this very clearly, there were a number of prominent doctors who said, just let everyone get infected, just let it run rampant, then we'll have herd immunity and we can all move on, somewhat neglecting the vulnerable people that would have died. So now it's worth revisiting that. Can we get herd immunity from natural infection? And the answer is no, unequivocally no. So first of all, immunity, even if we didn't have the variants to talk about, immunity wanes after a few months after natural infection. So 2 nice studies have looked at how durable the antibodies are after natural infection. You start to see the antibody levels come down actually within the first month. And after 8 months, only half of the people that were infected still have any protection that's going to help them. So no, natural infection, it does not lead to durable antibodies. It's not going to give us herd immunity. Also, we know before the variants ever came into our consciousness, we knew that some people were getting infected more than once. So there were the military recruits that got 2 infections. There were the Marines on the ship that had 2 infections. So not everyone makes great antibodies after natural infection. The milder your disease at the time you're infected, the less robust your antibodies are afterwards. And so the people who had mild infections are more likely to get second infections. So we knew that herd immunity was never going to happen with natural infection. And now what we know is that if you make antibodies to one strain, that may not provide full protection against some of these variants. And so we need vaccines for herd immunity, and we need them quickly before these variants really become dominant in the population. So that brings us to the topic of vaccines. So vaccines are really important. I'm very pro-vaccine, but I definitely have advised some patients not to get the vaccine right now. So let's just be real about the vaccines for the moment. I'm very pro-vaccine. I think they're essential for public health, but they need to be given contextually for each person. So let me just remind you of the 2 vaccines that are currently FDA approved. There's another one on the horizon, but let's work with the 2 that are actually FDA approved. So there's the Moderna vaccine. That's actually being given more in the rural areas of Pennsylvania. In Philadelphia, we primarily get the Pfizer vaccine. They are very similar. They're made the same way. They're both RNA vaccines encased in little globules of fat. They both have very comparable protection at 95%, and they both have really similar side effects. So the side effects are worth talking about. So I'm vaccinated because I work in a large hospital. I had side effects. I was happy to pay that price for protection, but the side effects are not nothing. Many people will get a fever after their 2nd dose and feel a little crummy for a day. So that is to be expected. That doesn't mean the shot has given you COVID. That's just a side effect of the vaccine. As I said, one of the most miraculous things about this vaccine development is this this strategy for vaccination, it has proven to be so incredibly effective. Not many of our current vaccines are this effective at preventing disease. So the RNA vaccines are highly effective, but let's talk for a minute more about the side effects. So I suspect some people on this webinar have gotten Shingrix. So that's the shingles vaccine. And I'm just listing the Shingrix side effects. So they're not that different than the side effects with Pfizer and Moderna. So pain at the site, fatigue, headache. The Pfizer and Moderna vaccines, it's a little bit more than Shingrix, but the side effects are actually quite similar. And what I like to tell people is, yeah, you know, I didn't love feeling crummy for a day. I didn't like having a headache, but it meant my immune system was working. The fact that I had those side effects meant that my immune system recognized the vaccine and was building a response. So yeah, you might feel crummy, but it does mean that some good things are happening in your body. So let me just address some of the worries that I hear in my clinic about these two vaccines. Oh, I was so surprised by this one. I actually had a woman say to me, oh, I don't want to do it and my friends don't want to do it because it will affect fertility. No, there was this internet myth way back before the vaccines were ever developed that if you made antibodies to COVID, it would attack your placenta. No, there are no COVID antibodies that attack your placenta. In my cafeteria, a woman asked me if the vaccine had a computer chip in it. So the smallest computer chip made that IBM is super proud of is shown in the figure. It won't fit through a needle. So no, there's no computer chips in the vaccines. Very popular is that the vaccine will cause disease. So these vaccines are wholly synthetic. There's not even a little piece of a virus in there. So there's not really a way for them to be infectious or to cause disease, but remember, you may well feel crummy for a day afterwards and even have a bit of a fever. It doesn't mean the vaccine gave you COVID. It just means your immune system is waking up and rising to the occasion. And then in my very own family, someone said, oh, I don't want the vaccine because it'll change my DNA. It will mutate me. No, the RNA doesn't get to your chromosomes. It can't get that far into the cell. There's just no way for it to get into your chromosomes. And then on the internet, some concerns that come up all the time is, oh, there are preservatives and I'm allergic to preservatives. I'm not going to get the vaccine. I've had problems with other vaccines. There actually aren't any preservatives in this vaccine. Remember, it has to be, these two RNA vaccines have to be stored frozen because there's no preservative. There's other reasons as well, but there's no preservative in the vaccine. Some people say, oh, I won't take the vaccine because it has blood products in it. Nope, I'll show you the ingredients in a minute. And some people say, I don't believe in abortion. I'm not going to get the vaccine because it was based on fetal research. No, these vaccines are actually made in bacteria and then in a test tube. So there's no human cells involved in the generation of this vaccine. So what are the ingredients? Really simple. You can open up the package insert or go online yourself. There are only 4 ingredients. So there's RNA. This is the message that tells your cells to make the spike protein, which is what you need to have happen to make an immune response to the spike protein. There's lipid, which is another name for fat. These make little globules that encase the RNA so it can be delivered into the cells. And then there's salt, just like our bodies. And then there's sugars to keep the little fat globules from merging. Like when you make oil and vinegar dressing and all the oil goes to one place and all the vinegar goes somewhere else, the sugar keeps the little globules separated. So there's only 4 ingredients. So no preservatives, nothing to worry about. Well, how do I know it's safe? It's so new. It's so new. How can I know it's safe? Well, each vaccine was tested in over 30,000 people, including people of color, people with pre-existing medical problems. Each participant filled out and is still filling out diaries and getting their blood checked. In addition, 40 million doses have been administered in the United States, many to people in healthcare like me, and we were recruited into a program called Be Safe, where we also fill out diaries. I just filled out one this morning, where we fill out diaries about any medical issues that have arisen after the vaccine. So there's now a huge experience with these vaccines. And other than the side effects that I mentioned, fever, headache, muscle ache, a sore arm, there's really not much signal of anything else happening. And you've probably had a new vaccine. So people are scared of these vaccines, but you have likely had a new vaccine in your life. So the Shingrix, when it was approved in 2017 for shingles, that was a new vaccine. And it also used fat molecules, and it also used a new immune stimulant. So you were getting a new vaccine with new technology. If you are a younger demographic, so I'm of an older demographic, but if you are of a younger demographic, you probably got the new meningitis vaccine, which also had novel technology used in that. So you have gotten new vaccines and probably didn't even raise an eyebrow about it. So I'm sort of surprised that these RNA vaccines are generating so much anxiety. Well, some practical questions before I end. Can I take Tylenol or Motrin after the vaccine? Yes to after the vaccine, no to before the vaccine. So there was a study in kids where they were pre-treated with Tylenol or Motrin, and that actually made their antibody levels lower after the vaccine. So the current recommendation is don't pre-treat. But if you have a fever or a headache, it's just humane to take some Tylenol and Motrin, and no reason to think that it's going to interfere with your antibody production. Second practical question, do I need to worry about allergies? So this is definitely an evolving story. So the current numbers are that there have been 4 allergies per million vaccines delivered. This is a smidge higher than the usual childhood vaccines where it's 1 per million, but in the same ballpark. So allergies don't seem to be dramatically different. I know they've been in the news, but it doesn't seem to be dramatically different for these vaccines. So there are some cautions. So most places that are administering the vaccine, if you have had a previous anaphylaxis to a vaccine, so not just a welt on your arm, not just a hive after a vaccine, but actually needed an EpiPen, then you're supposed to see an allergist before you get these vaccines. If you have had an allergy to some other injectable drug, and again, not a welt, not a hive, but true anaphylaxis that needed an EpiPen, then again, you're supposed to see an allergist before you get these vaccines. How long will my vaccine protection last? So I told you that natural infection isn't, the antibodies are not especially durable. The antibodies after these 2 RNA vaccines look quite a bit more durable over the short time frame that we've known about the vaccines. What does that translate to into how long they last? That's hard to know at the moment. And I'll just very briefly say, you probably heard that the Johnson & Johnson vaccine has applied for emergency use authorization. It will probably get approved. It's lovely. It's a single dose vaccine. It has a lower rate of side effects. It is based on a cold virus, but it's a non-infectious cold virus. It's essentially just the shell of the cold virus that's being used to deliver the spike message into the cells. It's refrigerator stable, so it's going to be a huge advance for third world countries, for rural parts of America. Similarly, it's been extensively tested, and it has a lower rate of side effects. Here's the downside. Johnson & Johnson doesn't have very many doses in their stockpile, so it's going to be months and months and months before we get much traction with the J&J vaccine. And then there's a Novavax where they have not yet applied for emergency use authorization. It's anticipated that they'll be next. This is a very traditional vaccine where they're injecting the purified protein. It has limited efficacy against the variants, but it does have fewer side effects, and it does seem to be very efficacious. So let's end up with where we're at now. So in Philadelphia, this is now if you want to sort of track the Philadelphia cases, you can Google Policy Lab COVID and you'll get a graph like this. So our lowest case rate was at the end of September. Lots of cheering, jumping up and down. There was a little liberalization, restaurants opened. And in fact, our fall winter surge, the peak has been quite a bit higher than our spring surge. Remember how anxious we all were in the spring? It felt like there was COVID everywhere. So our spring peak is indicated with the red arrow. Notice that our current, well, not our current peak, but our peak in December was twice as high. So we've gotten a little bit inured to sort of the danger aspect of having COVID-19 in our population. If you look at the dotted line, the projections are that the cases will continue to go down, in part because of the vaccines. I think the wild card here is that UK variant, because it spreads so much more easily. We're sort of in a race right now. Can we get enough vaccines into people's arms before the UK variant starts to take off? So how do we compare? I bet each and every person on this webinar feels like, oh my gosh, Philadelphia is doing such a terrible job. In fact, we are right on par. So we're sort of at the 10% mark of people that have gotten the vaccine. That's true for the country. It's true for the state. It's true for New Jersey. So it feels like Philadelphia isn't doing that great a job. And Lord knows I'm not an apologist. I'm not here to say that they couldn't have done better. They clearly could have. But in terms of numbers of doses, we're not really falling behind the rest of the country. So I said a minute ago that we are in a race. So we genuinely are. So we had a little bit of a head start in that there were some people that were infected that had immunity. There are some vaccines that have been delivered. So immunity so far is winning the race. But the variants for which the vaccines are ineffective and the UK variant that spreads more easily, if they get a traction in the population, they will outpace immunity and we will have yet another surge. So we've had 3 surges, we will have yet another one. So this race is a very apt metaphor. Everyone is trying to get as many vaccines as possible into people's arms so that immunity can win this race. So what does this mean? Well, we still have to wear masks. We're not there yet. If 10% of the population has gotten the vaccine, we are far away from having herd immunity. So we still need masks. We still need social distancing. We still need hand washing. That's not going away anytime soon. And then lastly, how can I get the vaccine? Boy, I wish I had the answer to this question. So I have a few tips for you, but I am not an expert on distribution and allocation, nor am I involved in the Department of Health. So what I will say is that in Philadelphia, the rules are different than the state. So if you feel like your friends in the suburbs have gotten the vaccine before you, yep, that's probably true. So in Philadelphia, they're focused on long-term care facilities, people in high density homes like correctional and group homes, people with essential duties, folks over 75 years of age, healthcare workers, and then there's a laundry list of high-risk medical conditions. So Philadelphia is still working its way through this list. They have not opened it up to the general population. How can you sign up? So there's a COVID vaccine interest form that's specific for Philadelphia. If you sign up right now, you'll probably be number 30,000. It doesn't feel very good, but at least you're on the list. So I would encourage you to do that. If you don't have a computer, you can use the call center. Excuse me. If you have a physician at Penn or at Jefferson, call them and make sure you sign up for the online portal, because the vaccine announcements are mostly going to come through the portal. They're not going to phone people. So you have to be on the portal to get the announcements about when they have vaccine. So if you have your primary care at Penn or Jefferson, A, call your primary care doctor, and B, sign up for the portal so that you can get the announcements. Walgreens is now giving vaccines, ShopRite, Rite Aid. CVS has to finish their contract with assisted living facilities, and then they will also offer the vaccine. Sign up on all of them. Go online, sign yourself up, and they do have a quiz to make sure you're eligible. But if you're in the eligible category, that's actually one of your best bets. So that's it. I'm going to stop sharing so you can ask questions.
Thank you.
I hope that was helpful.
Oh, absolutely. Absolutely. Thank you so much, Dr. Sullivan. And just to do the quick review of some of the stuff that we went through before we get to our questions, and as last time, we've got some really great questions in the queue that we'll get to. Um, it is good to learn that the strains started earlier than any of us may have fully been aware. So it's good to take that information as it is and not like a recent explosion. And it was also very interesting to learn about the different strains, the UK, South Africa, Brazilian, and as a wait and see with Los Angeles. Immunity wanes after a couple of months of natural infection, and mild infections can leave one open to reinfection. So it is also important to remember that while there are some good generalities about this virus we can lean on, we also have to remember that it can be very personal, and that it's not everybody is going to react and adapt in the same way. So that was very important. It's also important to remember that we can get infected more than once. So all the safety precautions, the very basic ones, are very good to stick to. And I was very happy that you talked about the side effects, because I myself have heard different opinions about after receiving the vaccine, if you feel maybe even like a post-flu vaccine where you feel feverish and tired and fatigued, that you shouldn't take medicine and let your immune system kick in. But you are saying that if need be, that you can do either Tylenol or Motrin.
Yeah, the effect of Tylenol and Motrin on the childhood vaccine responses was tiny. It was definitely present. So Paul Offit, who is my guru in all things vaccine related, he feels that it has to do with the pre-treatment, and it makes immunologic sense to me that that would be the case. So once you've got the fever, your immune system's already awake, and so dampening down the fever probably won't affect your antibodies.
Excellent. Thank you so much. And now I'm going to get to some of the questions. And Caitlin Ferry would like to ask, will the COVID and variants turn out like the flu, where we have to get a vaccine each year to protect against new variants?
Yeah, Caitlin, that's a great question. So the SARS-CoV-2 virus is an RNA virus, and influenza is also an RNA virus. The importance of that is that that category is more prone to mutate. So as you point out, flu mutates every year. And so that's why we have the annual vaccines. I think we were all hoping that that wouldn't be true for SARS-CoV-2. I think we were also hoping that we could, through public health measures and vaccine administration, maybe even eradicate this virus. That seems, if not impossible, a very long way off. So it is not impossible that you would need boosters to cover certain variants. But I will come back to this notion that the more the virus replicates, the more it reproduces itself, the more variants you will get. If we can get substantial immunity, not just in the US, but worldwide, it will very much slow down the development of those variants. And so there's still some hope that it won't be an annual vaccine, but there may be boosters needed if there are variants that emerge that are resistant.
So it is, once again, unfortunately, a wait and see and be attentive. Thank you. We do have an anonymous question about pregnancy and vaccine, and that is, in what situations would the vaccine not be recommended to a pregnant woman to get, and what is the reason why it would not be recommended?
So there were people in the licensing trials for both Pfizer and Moderna that were pregnant. So they didn't know they were pregnant, but they were pregnant and they got the vaccine. And as far as we know, there were no adverse events, but it was a small number. And pregnancy is a unique time where you're protecting not just yourself, but also the baby that you carry. So the official recommendations are to check with your obstetrician. So here are two things to think about. One is, if you make antibodies after you get vaccinated, you pass those antibodies on to your baby. So that's one of the reasons. if you have been pregnant in the last 5 years, you know one of the major pushes is to get pregnant women the pertussis vaccine so that their baby will have the protection from their mom's antibodies. Same idea with COVID-19. So there's definitely benefit to getting moms vaccinated. Here's, I think, the reservation that many obstetricians have. The first 2 trimesters are a very vulnerable time for fetuses. And so there's some concern that if the mom has a very strong fever and side effects with the vaccine, which can definitely happen, that just having had that fever might impact fetal development in some way. So it's a largely theoretical concern. So the official recommendations are for each pregnant woman to check with her own obstetrician, because it's very much about how much do you want the benefit of delivering those antibodies to your newborn versus the unknown risks that might happen if you have a side effect.
Excellent. Okay. Cheryl Lee Cook wants to ask, how long does it take to sequence/identify the variants? And in turn, how long does it take to detect it?
So it doesn't take long at all. I run a research lab, and we don't do this kind of work, but we could even walk into the lab and sequence it within a day. So it's not hard. The problem is, pains me to say this, but the CDC, which is really tasked with surveillance and performing the viral strain DNA sequence analyses, has had its budget cut for decades and decades and decades. It wasn't one administration. The CDC has had their budget cut consistently over about the past 20 years. People thought, you know, we're a developed country. We don't get cholera anymore. We don't get salmonella or typhoid fever. So why do we need a big CDC? So that's kind of biting us in the butt a little bit. So the surveillance efforts going on in the US are minuscule compared to that going on in other developed countries like Europe, even minuscule compared to some countries in Latin America. So we are far behind. And in fact, most of the sequencing going on in the US is being done at academic institutions because the CDC just doesn't have the manpower to do it.
Very interesting. And you have talked about pregnant women and the vaccine, but Ashley Singer is curious, can the vaccine interfere with fertility procedures?
No, other than most surgeons or people, not even like surgical procedures with a scalpel, but any kind of procedure where you're sedated, often they are unwilling to do it if you have a fever. If you've ever had one, you know, one of the first questions they ask you is, do you have a fever? How are you feeling today? Have you vomited? They don't want to do a procedure on someone who might be getting sick. And so to the extent that if you had a fever after the vaccine, I wouldn't schedule a procedure and the vaccine back to back. But other than that, there's no problem.
So this is a follow-up to that, which you may have answered. If you get one dose and then wait 3 to 4 months to get the second dose, what happens?
Yeah, you know, there's all kinds of crazy schemes out there to try and stretch the vaccines. And it certainly has been floated, and you may have seen that one idea is instead of giving people 2 doses, to give people 1 dose, and that way you can vaccinate twice as many people. But you don't get nearly as much protection. And the question is, if people then go and get the second dose 6 months later, a year later, are you finally going to get up to the 95% efficacy? And the answer is probably not. So no data on any other scheme other than the 28 days or the 21 days apart.
So as prescribed, that's good to know. And lastly, and this might be some more reiteration from you, is it unsafe to get the vaccine in the first trimester? From what is known, is it safe during all trimesters? And I do think you touched on this, but maybe it would help to revisit.
Yeah, so again, there's actually no data, which is why people are emphasizing have a conversation with your obstetrician. So what I would say is most obstetricians are more nervous about doing anything in the first and second trimester. By the third trimester, the fetus is really a baby and can live outside of the mom at that point. So the idea is development has mostly happened. And so the baby is more resilient if the mom has a fever, if something like that. And so I think most obstetricians are recommending the vaccine for most of their patients, but saying get it in your third trimester. But again, better to have that conversation with your obstetrician.
Good advice. What makes the variant, Jolynn Ross also raises this, what makes the variant more easily transmitted? What is the mechanism?
Yeah, so that spike protein that sticks out, I don't have my model with me today. So that spike protein that sticks out is like a handshake with our cells. And so the variant gives a firmer handshake. So the virus is more easily entered into the cell. So it's just that spike protein has a new shape related to the mutation, and it fixes more firmly to our cells.
I see. I see. Norm Whistler asks, if you have no side effects after the first and second injections, what does that mean about your immune system? That's an interesting one.
It is an interesting one. So of all of my friends and colleagues at work that have been vaccinated, only one had no side effects. And we all look at him and say, what, you know, how do you feel? So there's nothing to suggest that because you didn't have a fever or you didn't have a sore arm that you're not going to make good antibodies. There seems to be no correlation at all.
Oh, that's good to know. That's good to know. Nancy Biller asks, how can we access the record? Oh, Nancy, we'll definitely post that. I apologize. We'll definitely post that as we do with all of our community Zoom meetings on YouTube. And I promise we'll get the information out to you, everyone that's participated tonight, as well as the general population. And I am curious if I want to leave it open to anyone else that would like to ask questions. This is great that we have Dr. Sullivan, who is so versed in this, able to answer our questions and any other kind of conundrums that come up. And not that I want to, when you were talking about the CDC and the challenges that they are working with, when the CDC puts forth, and as well as with our discussion tonight about protecting yourself, when the CDC puts forth recommendations about returning to school, would you like to share any opinions about those recommendations? And again, you're not with the CDC, you're not with the School District of Philadelphia, but be curious to hear an opinion if you'd like to share it.
So I do have an opinion. So there have been now 2 rather large studies in Europe where they did contact tracing related to schools. There's actually also been a similar one in New York. And so all of those showed that the littlest kids, so kids less than 10 years of age, very, very, very infrequently transmit virus to adults, and actually pretty infrequently share virus between themselves, which to me as a pediatrician is pretty remarkable. I mean, kids share RSV and influenza like it's a candy cane. So there is something a little bit unusual about this virus in little kids. The little kids just don't spread it like they do other viruses. So I do think it would, and you know what's really surprising to me? Kids are remarkably accepting of masks. I have been stunned by that. So I think having the littlest kids go back to school is an easy step. I think it is going to really offload some of the pain that parents are having trying to do a job and teach their kids and run a household. It's been a very painful year for a lot of parents of young kids. And I think the risk is quite low. Now that's me talking about the data. I realize that there are issues related to the teachers union and so I can't speak to that, but if you just look at the data, the risks of kids transmitting the virus to an adult are quite limited. And that's without masking. When you add masking, and again, kids are remarkably willing to wear the mask, I think the risk is quite minimal. I think it's akin to going to the grocery store. It's a different situation for high school students. So they transmit virus as effectively as the college students, and college students are really good at transmitting virus. So that's a different situation. And you know, the kids in the middle and middle school are probably somewhere in between. So I think the youngest kids, we should get them back to school. They need school more. They don't tolerate the Zoom meetings. And I think the medical risks are minimal in that, not zero. There's no zero anymore, but I think the medical risks are quite limited to send the littlest kids back to school.
Well, I really appreciate that, because it's far easier to track, to collect data and to analyze the medical part of this. But sometimes the emotional and the psychological effects are not as easily quantifiable, and they're unique to every person, every household. So, and especially as we are in the winter of our discontent, where there's snow predicted tomorrow, it's colder than anyone promised us, and we're still dealing this pandemic 11, almost 12 months in. It's a lot to take. But if you had to, I'm looking, and I just want to check if anyone else has any questions. Oh, I see we've got one more in. And I'm going to say, Susan Wolf asked, why are they suggesting to wear a mask even around people who have been vaccinated or who have COVID, who have had COVID?
Yeah. So that's a tough one. So think about it this way. So people that have been vaccinated, so people that have had COVID lose their immunity relatively quickly. So we're going to take that off the table, because they really could catch COVID again. They could transmit it just like anyone. So the real issue is after vaccination. So you may remember there was this idea floated that we'll have vaccine passports and we'll wear them around our neck or something. And then everyone will know who's been vaccinated and who can move freely in the community. Well, that's just preposterous, right? So I think so first of all, being vaccinated lowers the risk of getting the disease by 95%. But remember, in the studies, there were still a few people who had symptomatic COVID. And there were also a tiny number who had asymptomatic COVID. So in this press to get the virus under control, I think it makes sense to just say, blanket rule, everyone wear a mask. Now, that's not going to be forever. And I agree, it's going to mean a bunch of people who couldn't possibly get the virus are going to be masked for longer than they need. But it's not like you can tell by looking at someone if they've been vaccinated. So imagine going into a grocery store and half of the people aren't wearing masks. So probably some of those folks have been vaccinated, and some of the people just said, oh, to hell with it, I'm not going to wear the mask. So it becomes a big messaging issue and a perception issue. So I'm sympathetic that the answers aren't perfect, but I understand where it's coming from to say, listen, for the moment, everyone keep wearing masks. I don't care if you're vaccinated or not. I'm not sure there's an alternative that would work.
And that's good advice. And I did see that Susan had her hand up and then it went down. So I'm hoping we answered all those questions there. And I'm just checking. A follow-up to that from Susan is, I have been vaccinated and want to be around others who also have been vaccinated without a mask. Oh, I'm sorry. I have been vaccinated and want to be around others who also have been vaccinated without a mask. That's the true question. But I think, is it still the same principle applies?
Yeah, if you're more than 14 days past your second dose, your risk of transmitting the virus is very low. Not zero, but very low. And so I have heard of people forming little vaccine pods. And so, it's not so different. So remember 9 months ago, so we were saying, well, maybe you can sit outside if you're 10 feet apart and talk. So there's no zero risk anymore. It's just a question of how much are you willing to accept. So if you've been vaccinated, your friend has been vaccinated, and you want to hang out together, and you're both more than 14 days after your second dose, the risk is tiny, not zero, but tiny. And if you accept that, I think that's fine. You're not putting anyone else at risk.
Excellent. Excellent. Thank you. And I'm just double checking our chat and our Q&A to make sure I get that everybody's questions and input, because until I see something else, as we kind of wrap up, it's safe to say that take advantage of the website, which we will send out to the public via Facebook, via our website, via our e-newsletter. Sign up for the vaccine regardless of your number in Philadelphia, of where they put you on the list. At least you're there and it's ready to go. And in the meantime, it's the simple factors of mask wearing, washing the hands, maintaining social distance. It's fatiguing after almost a year, but it's some of the best safeguards that can be used, correct?
Absolutely.
Any last thoughts you'd like to leave us with, Dr. Sullivan?
I know it's been long and hard, and I didn't talk about it, but I'm sensitive to the mental health downstream effects of the pandemic. And so you might have seen in the Inquirer that half of the population of Philadelphia has anxiety, 10% have depression. So when I said to now I can't remember the name of the person who said, could I maybe get together with a friend if we've both been vaccinated? I think we have to respect that we are human beings. We are social creatures. We need some of that. And so if you can find a way, not 20 people, but 2 or 3 people that have been vaccinated, if you can find a way to keep using Zoom and Skype and engage with people, I just think we need that. We're human beings. And so I didn't talk about it today, but I do recognize that it's important. And we have already been doing this longer than we ever imagined. We just have to realize that actually the goal line is in sight and we have to get there all together.
Well, you are incredibly informative and comfortingly positive. And I hope everyone shares a sentiment with me that we can do this. We can do this. It's going to take us doing it together, but this can be, we will make it past to the other side of this, if I can take that as your meaning overall. And I do want to let everybody know that this community meeting tonight, its recording will be posted to QVNA's youtube.com/queen page, qvna.org/Queen Village. You can go right away and sign up and you'll be able to get this as well as all the future ones. Dr. Sullivan, needless to say, I hope that if the time arrives, you will join us again. Your talks are very, very informative and your question and answer sessions are fantastic. And I want to wish you a great night. Everybody, thank you so much for joining us. We look forward to seeing you next time. Have a wonderful evening.